Greetings. My name is Rantia Kiyode from Howard University College of Pharmacy. I'll be speaking today on diabetes complications. Now what? Now, there is much discussion on the increasing prevalence of diabetes, and efforts have recently been focused on diabetes prevention, rightfully so. But the unfortunate reality is that for many people that are diagnosed with diabetes complications will likely develop. So today's presentation will discuss diabetes complication, its burden economically and clinically, and its management. Now, this next slide just basically itemizes the objectives that will be discussed today. I will plan to discuss the prevalence of diabetes complications, describe the economic and clinical burden of uncontrolled diabetes complications, explain the mechanism of common diabetes complications, and outline the pharmacological and non-pharmacological management of diabetes complications. Now, on this next slide, I wanted to depict pictures to basically stimulate the thought on the severity on diabetes complications, the severe state, basically. The fact that people with diabetes are living longer, and as such, the long duration of the disease will further contribute to them developing diabetes complications. However, it's important to note that controlled diabetes and controlled comorbid conditions that are present in the state of someone that has diabetes, and along with proper routine screenings and routine immunizations, will strongly lessen the chance of patients actually developing severe complications of diabetes. So the pictures depicted here on this slide is not necessarily a reality for every single patient. So patients' blood sugars are controlled, and if their comorbid conditions or metabolic conditions are also controlled with appropriate routine screening to prevent the conditions and to delay the progression of the complications, likely patients will not experience the examples I have depicted on these slides. Now, what we have here on the graph here is based on the 1980 to 2009, the Center for Disease Control and Prevention graph. There's evidence that the number of new cases of diagnosed diabetes among U.S. adults has been on the incline. And I would say the tipping point for this sharp increase occurred around the late 1990s. This data really highlights the significance of diabetes prevention, management, and diabetes complication prevention and delay, and how important that would be, since there is a trend for increase. This next slide here gives more specifics on the prevalence of diagnosed diabetes based on age. And when we look at the age spectrum, diabetes still remains more common in the elderly population, followed by those between 45 and 64 years of age, and then by those 20 to 44% of age. Again, it's important to realize that the young adolescent population are now beginning to have more diabetes diagnoses as well, especially among the minority population, minority youth specifically. Now, at the bottom of the slide, you will find that the race and ethnicity mix of U.S. adults with diabetes. The highest prevalence of diabetes still remains to be in the non-white populations, the highest being among American Indians and Alaska Natives with 16.1%, followed by the non-Hispanic Blacks with 12.6%, then the Hispanics 11.8%, Asian Americans 8.4%, and lastly the non-Hispanic whites at 7.1%. According to the most recent statistics we have available in diabetes, the 2011 Centers for Disease Control Prevention data, there are about 25.8 million, so about estimated 26 million children and adults in the United States with diabetes, which makes up 8.3% of the population having diabetes. Now, it's so amazing because, every time the data is released, you tend to see an increase in this number. And because specifically in 2007, which was when we had the last data by the CDC on diabetes, the total population at that point was 23.6 million. So about 4 years prior to that, 23.6 million, this number has gone up to 25.8 million, approximately 26 million. Now, among the 25.8 million, 18.8 million people are diagnosed with diabetes, and then 7 million people are estimated to be not diagnosed at all. And I think what's probably the most scary out of all the numbers we have on this slide is the 79 million people that are said to have pre-diabetes or at increased risk of having diabetes. And the key is if these patients are not managed, or the pre-diabetes state is not prevented from converting over to diabetes, that's going to be a lot of a burden for the healthcare system. For many people, just having 50% of the 79 million numbers of people here convert over to diabetes would be very catastrophic. And then, of course, we have at the bottom here the new cases. About 1.9 million new cases of diabetes are diagnosed in people aged 20 years and older in 2010. So again, the idea is that more and more people are having diabetes. The next slides depict 8 major clinical burden or clinical conditions or complications associated with diabetes. And keep in mind that these are the major, more common complications of diabetes. And when you look at this slide, you can see that diabetes literally impacts just every aspect of the body, from the head, in the case of stroke, to the toes, form of nervous system or vascular disease. So diabetes complications extends beyond also just the body, to the psychosocial context, as in the form of depression. So when you look closely on this slide here, you can see I have heart disease or stroke here in the center point, because it remains to be the leading cause of death among people that have diabetes, whether it's type 1 or type 2. And then beyond that, patients that have diabetes, tend to have dental disease. They're more severe. Nervous system disease with amputations, kidney disease, blindness, hypertension, which we're going to go in a little more in depth later on, tend to have more complications with pregnancies. And then in acute situations, more likely to have DKA. In the absence of insulin, they have insulin deficiency. They can have DKA, diabetes ketoacidosis is in type 1, and HHNK is in hyperosmolar hyperglycemic conditions. So now looking more closely into diabetes complications, you can basically categorize them as either vascular or non-vascular. So we have on the slide here the vascular complications of diabetes. But then the non-vascular complications are also possible for patients to experience. So those would include dermatologic conditions, infections, more greater frequency of infections and severity of infection, hearing loss, and so forth. With the vascular complications, you can divide them into 2 segments. One segment being the microvascular, affecting the large vessels. So that would be the stroke and the heart disease and hypertension, the peripheral vascular disease, and some foot problems, specifically having to do with the peripheral vascular disease. And then the other segment would be the microvascular complications, which are the complications affecting the smaller vessels. So examples we have on the right-hand side of the slide would be retinopathy, diabetic eye disease, renal disease, nephropathy, nerve disease, neuropathy, and also we can have some foot problems as a result of neuropathy as well. As I mentioned on the last slide, there's some potential for patients to also have non-vascular complications. And the key is that in general, individuals that have diabetes tend to be at a higher risk of developing the listed conditions we have on the slide, such as hearing loss, more likely to have severe periodontal disease, obstructive sleep apnea, depression, fatty liver disease, low testosterone, certain cancers, fractures, and really the list goes on, because this is not really a full exhaustive list. So in continuing to discuss the clinical burden of diabetes, we would like to go more in depth on the prevalence of diabetes complications. So heart disease and stroke are very prominent in those individuals that have diabetes, because again, they remain to be the leading cause of death, heart disease, among those patients with diabetes. So in terms of the prevalence, heart disease death rate is about 2 to 4 times higher in diabetes patients. And keeping in mind that individuals that have diabetes are as if they already have a heart attack, for example. And a stroke risk is also 2 to 4 times higher in diabetes patients. So with hypertension, 67% of diabetes patients have blood pressure that were uncontrolled or use some form of blood pressure control medication. And with blindness and eye problems, diabetes is the leading cause of blindness in adults, and it's been so for some time now. So more in the diabetes complications prevalence. So kidney disease is a major one. Diabetes is the leading cause of end-stage renal disease, and many of these patients tend to eventually have to be on dialysis treatment. Nervous system disease, 60 to 7% of diabetes patients have some form of nervous system damage. And then amputation, diabetes is the leading cause for non-traumatic lower limb amputations. So what I have here on this slide as diabetes and complications, and you notice that I have the arrows pointed to diabetes and to complications. And the point I wanted to make is the fact that they're really very much inseparable. It's sort of much like separating salt from water. You cannot really manage diabetes without managing the complications of diabetes. And that is why it is important to take preventative measures for diabetes complication prevention before it sets in, through routine screenings for the patients, routine screenings on the major complications. So routine screenings for, cardiovascular conditions and the neuropathy and nephropathy and retinopathy. And then, of course, optimal management of the diabetes as a form of glycemic control, and then management of the comorbid state, cardiometabolic conditions that might be present, is all important measures to make sure that the complications do not occur. Because uncontrolled diabetes is what leads to many of the complications. When patients' diabetes are controlled, it really minimizes many of the complications the patients will experience. I'd like to talk about the natural history of type 2 diabetes. And the point I want to make with this slide is the fact that many patients with diabetes, type 2 specifically, already have complications taking place prior to their diagnosis of diabetes. Generally, about 7 years before diabetes diagnosis, many of these patients generally have cardiovascular complications occurring. And this is during the state of glucose intolerance, whereby they have impaired fasting glucose, impaired glucose tolerance. So it's important to realize this. And that's why at diagnosis, you really have to start checking the patients and assessing their complications, and then begin to put in measures to prevent further progression of the complications. Beyond cardiovascular complications, also microvascular complications too occur before diagnosis. But usually the cardiovascular occurs much earlier, before at least about 2 years or so earlier before microvascular complications. And that's really the point I'm trying to make here. So, and this is the case because, again, also individuals are not diagnosed again soon, right after they have type 2 diabetes. Unlike in the case of type 1 diabetes, whereby patients are diagnosed, right then when they have the type 1 diabetes, and usually complications will occur maybe later on after the diagnosis, about 5 years or so down the line. So it's important to really keep this in mind. So that brings on the importance of having early diagnosis of diabetes take place to prevent the complications or delay it as much as possible. Now we are going to discuss the financial burden of diabetes care. Now, in March this year, 2013, the American Diabetes Association released new data on the cost of diabetes mellitus care in the United States. And the total cost of diagnosed diabetes in 2007 was about $174 billion. And this actually rose by 41% to $245 billion in 2012, over a 5 years period. So we see a strong increase in the cost of care of diabetes patients. So the total cost here that we're referring to includes both direct medical and indirect medical costs. So this includes lost productivity, employment rate, and unemployment and so forth. So you see here that there's an increase not only in the clinical burden of diabetes, but also the financial burden of diabetes as well. So the question to ask on this slide here is, so what is driving the U.S. medical cost for diabetes? What is the main driver? Well, for one thing, the medical costs are about 2.3 times higher in diabetes patients than those without diabetes. Okay. And then what we realized when they looked at the new data that was released this year, the $245 billion, they found that the increasing prevalence of diabetes is actually the main driver, not necessarily the cost of medical care or of diabetes or the cost of drug therapy or the cost of the drugs or the diabetes supplies. But the main driver is the fact that more and more people are actually developing diabetes. That's what's driving that financial burden, the medical costs to be higher. In fact, when they looked at the diabetes drug therapies and diabetes supplies, they only accounted for about 12% of the total medical cost in 2007 and 2012. So you can note, those really haven't changed. It's the numbers, the fact that the shared numbers of people with diabetes are increasing, really what's driving the medical cost of diabetes. Now that we've discussed the prevalence, we've talked about the financial and the clinical burden of diabetes, we're going to briefly just talk about the mechanisms behind the diabetes complications. One thing, however, to make is that it's not fully elucidated in terms of being clear on exactly how the mechanisms, how it takes place to cause the complications to take place. However, it is clear that hyperglycemia is the main or central trigger in the development of diabetes complications. Again, the four major proposed mechanisms or pathway are the advanced glycosylation end products or AGE, sorbitol pathway, protein kinase C, and exocysteine pathway. So again, those are the major pathways that have been hypothesized or proposed to be causing the complications to take place, primarily in microvascular and also in microvascular complications as well. So now looking more specifically with the individual pathways briefly, well, advanced glycation end product, it just basically have to do with, products that are formed as a result of, hyperglycemia, excessive glucose level, because the level of hyperglycemia parallels with the level of these AGE products that are formed. So they are formed through non-enzymatic reaction of glucose combining with amine groups on proteins and nucleic acids or lipids. So what stimulates them is really the hyperglycemia and oxidative stress and lipids. So upon their formation, they activate a series of intracellular activities and release of pro-inflammatory cytokines and other processes, thereby hastening atherosclerosis, glomerular dysfunction, endothelial dysfunction, and so on. So they have, a role to play in both the micro and macrovascular complications of diabetes. The next pathway is the sorbitol pathway, also known as the polyol pathway. It's a result of glucose conversion to sorbitol via the aldose reductase enzyme. So hyperglycemia leads to this increased metabolism of glucose, through this pathway into sorbitol. And the increased sorbitol then promotes reactive oxygen products, leading to cellular dysfunction. At the same time, this rise in sorbitol in the cells leads to high cell osmolality, thus causing osmotic changes and damages such as retinopathy, by inducing retinopathy and neuropathy. And there have been efforts actually to inhibit those aldose reductase enzymes. So aldose reductase inhibitors were one particular product was tested in clinical trial and failed in the phase 3 point of the clinical trials. But we do have others, however, in clinical trials as I speak right now. And the goal is basically to reduce the microvascular endpoints. Again, we just have to wait and see, if they will be successful. Even though in rats, we've had topical administration of the aldose reductase inhibitors, and they've been shown to prevent cataracts in rats. Again, with time, we will know whether they will be successful in humans in reducing microvascular endpoints. The next pathway that we have is the protein kinase C pathway, and really has to do with hyperglycemia leading to increased formation of diacylglycerol, which leads to activation of the protein kinase C. And the protein kinase C then will modify selected genes of proteins in the endothelial cells, therefore leading to the complications. Now, there have been some studies involving protein kinase C inhibitors as pharmacological options, specifically in diabetic nephropathy. Again, we just have to wait to see. One particular one with product protein kinase C inhibitors was tested, but was abated due to failure in clinical trials. So the key is really to see in the future, perhaps in the future, something will pan out on this area. Now, the last pathway that we have, major pathway, is the exocysteine pathway. And this has to do with the increased flux through the exocysteine pathway due to hyperglycemia, and which leads to the generation of fructose 6-phosphate. And the fructose 6-phosphate then undergoes a series of cellular metabolism, resulting in pathologic changes in blood vessels of diabetes patients. And that is not all. We also have growth factors to play some important role in some diabetes associated complications. The production of the growth factors are increased generally in the hyperglycemic state. One of the growth factors commonly is the VEGF, the vascular endothelial growth factor A, is increased in diabetic proliferative retinopathy and improves with laser photocoagulation. And we also have the TGF-beta. The transforming growth factor beta is also increased in diabetic nephropathy as well. And other growth factors have also been proposed in diabetes-associated complications. So the unifying mechanism, when you look at all the pathway, is the hyperglycemia is a central trigger point that really leads to reactive oxygen species in the mitochondria, therefore perhaps possibly activating all of the four proposed mechanisms. However, it remains unclear on if the same mechanisms are operative or dominant in all of the diabetes complications. Again, so we really need more and more research to be done to fully understand the mechanisms. Now we're going to switch gear now, moving beyond the mechanisms to talk about the complications in clinical trials. The first clinical trials I will speak on is the Microvascular complication trial with the diabetes control and complication trial. So I'm going to talk about the DCCT trial, which was actually done involving type 1 patients. The goal of this particular study is a landmark study that many of us, I'm sure, are familiar with, was really to look on, to assess the relationship between tight glycemic control on microvascular complications in type 1 patients. This was done some years ago between 1983 and 1993. So the patient population in this DCCT trial were type 1 patients, young patients, mean age 27, generally healthy patients, no CV, they were excluded if they had, certain cardiovascular conditions and so forth. And then the intensive group were on 3 injections a day or pump, where standard group were on 1 to 2 injections a day. So overall, when you look at the end of the study, we found out that those individuals who were in the intensive group who achieved A1C about close to 7, about 7.3%, had less microvascular complications, nephropathy, retinopathy, neuropathy. Not much was really seen with microvascular. It was not really significant, maybe perhaps because the patient population were young patients and they had low CVD risk, so perhaps. But certainly those who were in the conventional group, they achieved the A1C about 9.1%. So they did not have, of course, as much reduction. So the point of the DCC trial is that having patients to reach a glycemic control about near 7 was certainly helpful in reducing those small vessel complications of nephropathy, retinopathy, and neuropathy. So this was a very major outcome and translated to, how we practice even today. Now, the early initial trial, the DCCT trial, again, yielded information to help us to realize that tight glycemic control is beneficial in reducing the small vessel complications or microvascular complications. But it really did not answer the question of the large vessel, the macrovascular complications. So then we have follow-up trial that was completed, which is DCCT-IDIC trial, which is the epidemiology of diabetes interventions and complication trial, which basically after 10 years of follow-up, so the follow-up these patients at the end of the first trial, and despite narrowing of the glycemic differences, so after this initial study ended, they followed all these patients for 10 years, they were on their own. What they realized was that those individuals who were in the tight glycemic control basically had a A1C of about 8, and those who were the conventional control of a 9% went to 8. So those who were intensive control went from a 7 to an 8 during the 10 years period, and those who were in the conventional group went from a 9 to 8. So now at this point, both the intensive and the standard group have about the same A1C. And despite this narrowing of glycemic differences between those two groups, they realized that those individuals who were in the intensive group had lower cardiovascular events. Looking at non-fatal MI, CV death, stroke, with relative risk reduction by 57%, even though the A1C was the same. So this led to the conclusion that early intervention is effective in cardiovascular delay. And they also noticed some improvement with microvascular endpoints as well. And they basically alluded that this has to do with metabolic memory, that the fact that the patients in the intensive group had exposure to tight glycemic control early on was still yielding benefits years down the line. Hence the importance of having patients in the early stage of their diagnosis to have them controlled early on. So not only prevent microvascular complication, but also macro, the large vessel complication. Now, this is in type 1 patient population. So I'm going to discuss the next slides in the type 2 population. Now, the next study that was done was the United Kingdom Prospective Diabetes Study, UKPDS study, and basically looked at the same thing that the DCCT trial looked at, other than this is in type 2 patient population. The patients here also newly diagnosed, age about 54 years of age, and they evaluate the multiple regimens of diabetes therapies on the role of intensive glycemic control on diabetes complications. So the intensive group, they were on a combination of insulin or sulfonylurea, metformin, whereas the conventional group were on diet changes plus pharmacological therapies to prevent symptoms. So by the end of the study, the intensive arm achieved the A1C of about 7, and then the conventional arm received an A1C about 7.9%, so change about 0.9% A1C. So even with that small A1C reduction, about 0.1, there was a major reduction noted with microvascular complications with those individuals in the intensive group. And there are also other findings, such as blood pressure control, they realized contributed to the reduction of the macrovascular and the microvascular complication, because they realized that the blood pressure, about 144/88 millimeters of mercury, lowered the risk for diabetes-related death, stroke, and microvascular endpoints, and retinopathy and heart failure as well. So this basically goes along the line of the DCCT trial, showing that tight glycemic control was beneficial in reducing small vessel complication, and also the importance of blood pressure control in reducing not only the small vessel complication, but also the large vessel complication as well. Now, this trial did not really yield strong supporting evidence on the tight glycemic control impact on the large microvascular complication. There was a trend towards that, but then that outcome was not significant. Microvascular complications in type 2 diabetes, very similar, the follow-up here, very similar to the EDIC follow-up DCCT trial. So with the UKPDS follow-up trial, at the end of that initial trial, patients were followed for 10 years, and they realized there was a narrowing of the A1C during that 10 years period. And so even the fact that they had similar A1C, they realized those individuals who were in intensive group earlier on actually has significant myocardial infarction reduction, about 15%, with a p-value of 0.01%. So it was beneficial, even though the A1C was the same with the standard group. So they contributed this impact has to do with the memory effect or legacy effect, very similar as the follow-up in the DCC trial, that getting patient control early on in their disease state, was actually beneficial in the long run in reducing not only the small vessel microvascular, but also the large vessel microvascular complications as well. So what is the bottom line? The bottom line really is the fact that early treatment of diabetes in type 1 and type 2 patients may delay microvascular complication. And that's been sort of like $1,000 question, $1 billion question there. And also there remains benefit in the reduction of the microvascular risk with early diabetes treatment as well. So to summarize the evidence for A1C lowering with the microvascular diseases, looking at the DCCT and UKPDS trials at glance, the fact is retinopathy and nephropathy are reduced both in DCCT and UKPDS, and you see a major decrease in neuropathy with the DCCT trial here. With the cardiovascular disease, again, these patients were younger patients and they did not have really major cardiovascular events, but you did see a trend. Was not a significant trend, but a trend of cardiovascular disease benefit with the UKPDS type 2 trial. Now, to further understand, the relationship between tight glycemic control and microvascular complications, other studies have been done. Other major studies have been done. Specifically here, the CORE trial and ADVANCE trial have been done, and they provide very insightful information that's translated to how we practice today. Again, this is just two of the other trials that have been done along this line. Now, with the CORE and ADVANCE trial, they basically wanted to know how low can you go. Specific with the CORE trial, they aimed for A1C goal of 6%, about 6%, less than 6%, close to 6% in the intensive group, whereas ADVANCE trial aimed for about 6.5%. And with the CORE trial, they didn't quite get to the 6% that they aimed for. They had to end the study early because there was more mortality noted in the intensive group versus the standard group in the CORE trial. The ADVANCE group study did note that the intensive group did achieve an A1C of 6.3%. So when you look at the demographics or the characteristics of this patient, you note that the CORE and ADVANCE patients are older patients, and these are all type 2 patients, diabetes patients. Whereas we remember when we looked at the UKPDS trial, those patients were younger. And you also note that the CORE and ADVANCE trials had patients who had, quite a few of them, a third or so, that history of CVD, unlike with the UKPDS trials or healthier patient populations. So when you look at this and you see the conclusion that with the core trial, there was also more hyperglycemia by 16% and the weight change about 3.5 kilograms. Well, they ended the study early, as I said, because of more mortality. We don't really know all the reasons, the exact cause. There's been some proposed hypothesis to why there were more deaths noted in a core trial, such as perhaps the hyperglycemia. But again, that is one of the major postulations on that, but then it's not quite fully elucidated. Then when we look at the advanced trial, they did not note mortality with the intensive group, but one thing is they did not necessarily note a benefit. There was no noted cardiovascular benefit with advanced trial with those individuals who were in intensive group of A1C, but they did note continuously improved microvascular benefit with less nephropathy and less microvascular complication in the advanced trial. So what do we make of the results of the core and advanced trial? When they looked, however, with the sub-analysis of these two trials, they realized those younger patients who were healthier, who did not have major complications or comorbidities, actually benefited with tight A1C. So that was basically the bottom line from the trials. And the key was to individualize therapy. So in summary, summarizing the core and advanced trial, you can best state it and phrase it as not being crazy with A1C or lazy with A1C. Because high blood glucose is quite detrimental, as we saw in the core trial. But extremely low blood glucose also appears deadly in some patients. Patients who have history of severe hyperglycemia, limited life expectancy, advanced microvascular and macrovascular complications, extensive comorbid conditions, long-standing diabetes, as we saw in a core trial, having those patients achieve low blood glucose levels appears to be deadly. So generally, it's in a core type patients, it's better for the patients to be alive with the A1C of 7.5% than for them to be dead with the A1C of 6.4%. That's really a take-home message. So you have to individualize therapy depending on the patient characteristics. Whereas we know in an advanced type patient that the patients were still experiencing benefits with microvascular risk with the A1C of about 6.3%. So the key is to individualize therapy. Those individuals who are healthier and younger will probably benefit from a tight glycemic control, whereas those individuals who are older and sicker will probably need a A1C that's perhaps maybe near 8 or less than 8. So in summary, based on the evidence that we have for the microvascular disease and A1C lowering, when you combine the DCCT, UKPDS, ACCORD, and ADVANCE together, there's benefit with delayed benefit at least with DCCT, UKPDS trials, and appear to be harmful with A1C less than 7, and appear to be no benefit with advanced trial. Again, when you look at the sub-analysis, there are patients who benefited from A1C that's less than 7 in both ACCORD and advanced trials. So then we're going to move on to managing the diabetes complications once they've occurred. But keeping in mind, in terms of the spectrum for diabetes complications, the key is to prevent the complications and then to certainly delay the progression of the complication and then to reduce the severity if the complications do occur. The first complication we're going to talk about is cardiovascular complication. That's because cardiovascular disease is the leading cause of death in patients that have diabetes. So it's a major clinical burden. And so the way that is managed is really by managing the coexisting CVD risk factors. So many of these patients tend to have hypertension, dyslipidemia, coagulability, and smoking. So the key is to manage those individual risk factors, and that will oftentimes help to reduce the overall cardiovascular disease event. Starting with hypertension, the blood pressure goal, according to the American Diabetes Association, for diabetes patients actually changed with the new guideline that was released, January 2013 this year. And this is really based on available clinical data. So then now the systolic blood pressure goal for patients who have diabetes now is less than 140 millimeters of mercury, and diastolic blood pressure remains less than 80 millimeters of mercury. And then again, this has to be individualized. This is not necessarily for everyone, but that's basically the general recommendation. However, for some patients who are younger, if they can achieve a systolic blood pressure of less than 130 without complications, with few complications or few drugs, that would be great. Less than 130 is still possible. but again, generally less than 140. And the driving force for this recommendation is the strong evidence that systolic blood pressure greater than 140 is harmful. And the clinical trials we have really haven't proven or shown much improved cardiovascular event or outcomes when the systolic blood pressure were less than 130. So it's really because, again, we didn't notice much benefit with systolic blood pressure less than 130, but certainly the blood pressure greater than 140 is harmful, hence the new recommendation. Now, for those individuals that have systolic blood pressure greater than 120, between 120 and 140, lifestyle and beyond, lifestyle certainly is important. If they're overweight, to lose weight, to engage in physical activity, and to adopt the DASH diet, which is a dietary approach to stop hypertension, which includes low sodium intake, increase in potassium, moderate alcohol intake. And the lifestyle is really something that's not just to be done when the blood pressure is between 120 or 140. It's really just, a lifestyle forever. What's expected for all patients to engage in, and even when they need pharmacological therapy options as well. So now, for those individuals that have hypertension already and they have diabetes, the first line therapy would be ACE inhibitor, angiotensin converting enzyme inhibitor, or ARBs, angiotensin receptor blockers. If patient does not tolerate one class, they can certainly substitute for the other. It is highly discouraged for them to use both together because, again, more increase for side effect without necessarily yielding more benefit for the patient. Now, many patients will likely need 2 or more drugs at maximal doses to get their blood pressure controlled. And so if ACE or ARBs are not getting the patient where they need to be, there'll be a need to add a second drug option. If not controlled, they could add amlodipine or thiazide if the GFR is 30 or greater, at milliliters per minute or greater. And in a case whereby their GFR is less than 30 milliliters per minute, a loop diuretic would certainly be ideal to use. Now, in the case whereby diabetes patients has abnormal blood lipids, dyslipidemia, the LDL cholesterol is the primary marker that we often look at to get the patient a goal. And the LDL goal would be for most of the patients to be less than 100 milligram per deciliter. Now, for those individuals that have overt cardiovascular event, they've had a heart attack, a stroke already, LDL goal of less than 70 milligram per deciliter would be more ideal for those patients. Now, alternative therapeutic goal, if the patient does not, with high intensity, if they're already on high dose statin and they're not able to reach LDL goal of less than 70 or LDL goal less than 100, alternative goal, therapeutic goal would be to have a reduction in LDL about 30 to 40% of the LDL blood cholesterol reduction from baseline is also an alternative therapeutic goal in that situation. Now, with triglycerides, the goal would be less than 150 milligram per deciliter, with HDL in men greater than 40 and women greater than 50 milligram per deciliter. Now, for the management, lifestyle really is just the first way to start and to continue to engage in for all patients that have dyslipidemia, and that involves reduction of saturated fat intake, trans fat, cholesterol intake, an increase in omega-3 fatty acids, viscous fiber, plant stanols, and sterols, weight loss if necessary, just as we discussed in the hypertension situation, and smoking cessation is absolutely necessary. Now, in terms of at what point you would start a statin therapy for patients that have diabetes, it's important to realize this, and I think many people miss this, that regardless of what the lipid baseline level is for patients that have diabetes, for the fact that they have diabetes, and if they're over 40 years of age, if they have just one or more other CVD risk factors, which is something that many patients will have, they need to be on a statin. So which means if you have a patient who has diabetes, who has normal lipid levels, if for the fact that they're over 40 years of age and they have maybe perhaps hypertension, or they also have, maybe they're also smoking, or they also have maybe microalbuminuria, or any one of those, or family history, they really need to be on a statin therapy, and I think many people miss that. And then beyond that, if someone, of course, has diabetes, regardless of their lipid level, if they've had an event, they've had a heart attack, they've had a stroke, they certainly need to be in a statin therapy as well. Now, for those individuals who have lower risk, those patients who have not had an overt CVD event, they're younger than 40 years of age, the main thing is to have their LDL to be less than 100. So if the LDL is greater than 100, or if they have multiple CVD risk factors, they could benefit from a statin therapy. And then some patients who have low HDL or high triglycerides, nicotinic acids, niacin, or fibrates could be beneficial. However, if someone is not a goal with statin alone, again, getting them to have a reduction of 30 to 40% from baseline LDL level is really a great alternative therapy. Now, the idea of combining a statin therapy with another lipid-lowering medication such as niacin or fibrate is actually strongly not recommended. It's not recommended, not strongly recommended, generally not recommended because there's been no evidence of CVD reduction. Most of the studies that have been done have shown more of a CVD reduction with statin therapy and not with the niacins or the fibrates. Now, in the case of non-HDL cholesterol, the American Diabetes Association really doesn't give a lot of clarity on the role of non-HDL cholesterol in managing dyslipidemia patient. However, the American Association of Clinical Endocrinologists, ACE guideline, does consider the role of non-HDL cholesterol in managing patients that have dyslipidemia. So if someone has non-HDL cholesterol, if the LDL goal is less than 70 for a patient, the non-HDL cholesterol goal would be less than 100. Kind of add, minus the difference of 30 there. And then apolipoprotein B would be less than 80. LDL goal is less than 100, and non-HDL goal would be less than 130. And apolipoprotein B cholesterol goal would be less than 90. Now, moving on the topic of coagulability, generally, for those patients who've had an event before, aspirin 75 to 162 milligram per day is recommended in those patients who have diabetes and who have a CVD history. So that's pretty clear for secondary prevention. If someone is allergic to aspirin, they can use clopidogrel, Plavix 75 milligram a day. And they can do a combination of aspirin and clopidogrel up to a year after having an acute coronary syndrome. Now, for the primary prevention in 2010, the American Diabetes Association and American Heart Association issued a caution on the primary prevention with aspirin in type 1 and type 2 patients at increased risk. So basically, the recommendation for primary prevention would be for those adults with diabetes who have no CVD history, but they're increased risk. So there will be men over 50 years of age, women over 60 years of age with diabetes, plus one more CVD risk factor. So whether it's smoking, dyslipidemia, hypertension, family history, amenorrhea. So that's important to know, not to necessarily recommend aspirin for everyone who has diabetes just because they have diabetes. They also have to have meet the age criteria and the risk factor criteria as well in the case of primary prevention. I cannot overestimate the importance of smoking cessation and how we as healthcare providers should always reinforce the importance of smoking cessation at every opportunity with our patients, because smoking by itself is a CVD risk factor, and smokers are more likely to have the microvascular complications as well. So it's important that we offer smoking cessation counseling information such as a 1-800-QUIT line to our patients. And studies have shown that we really need to combine smoking cessation counseling plus pharmacological options many times. Either alone generally are not quite as effective as when you combine the two. So in terms of the pharmacological options, we have the nicotine, replacement therapies, and also we have the non-nicotine pharmacological options as well. So we can certainly share that with our patients. Nicotine replacement therapy, some are prescriptions, some are over the counter. So we have various formulations as listed on the slide. We also have the varenicline and bupropion, which are pharmacological non-nicotine therapies. They're available options for patients as well. So in terms of managing the microvascular complication, but before I discuss that, we just finished discussing the cardiovascular complication, which is a major microvascular complication, diabetes. But I just want us to keep in mind that the peripheral vascular disease, PVD, which is also considered to be a cardiovascular related condition or microvascular condition, is really managed very similarly to the cardiovascular condition. Many patients just need to basically have their individual risk factors managed. So for many of those patients who have PVD, peripheral vascular disease, they tend to also have hypertension, dyslipidemia, or uncontrolled glucose level. So the key is to have those individual risk factors controlled, as well as smoking cessation as well. Just wanted to mention that. Now, I'll continue on the microvascular, so retinopathy here. In the management of retinopathy, the key is to reduce vision loss for these patients. They will tend to have, whether it's non-proliferative diabetic retinopathy or proliferative diabetic neuropathy and macular edema. So the way they are treated is generally with blood pressure control to reduce and delay retinopathy progression, and then laser photocoagulation therapy. That's basically the standard treatment for many of these patients. Next, we're going to talk about neuropathy management. For those patients that have neuropathy, they could either be the peripheral neuropathy, or also known as distal symmetric polyneuropathy, DPN, or they could have autonomic neuropathy. So with the distal or peripheral neuropathy, usually it will be assessed through the loss of the 10-gram monofilament perception and reduced vibration perception, and then the numbness, tingling, stocking glove, mode of sensations. Whereas the autonomic neuropathy patients will experience resting tachycardia, exercise intolerance, orthostatic hypertension, and a lot of GI side effects and issues, and autonomic failure will be noted as well. It's important to realize for those patients that have peripheral neuropathy, the goal is really to delay and prevent the progression of symptom severity, as the nerve damage ensues. Because once the nerve damage is taking place, they are basically permanent and they cannot really regenerate generally. And so the other goal is to improve functional level to make the patient comfortable, such as sleeping through the night, and to prevent amputations and ulcers for these patients that have peripheral neuropathy. And the approach really generally is with just achieving glycemic control, and then providing pharmacological treatment options for the pain, managing the pain symptoms with many products available such as the Lyrica, pregabalin, and Cymbalta, duloxetine, the gabapentins, and the TCAs, the tricyclic antidepressants, amitriptyline, and so forth are certainly first-line options. And also the patch lidocaine will be options for patients to use as well. Now, for the autonomic neuropathy, again, getting the patient to achieve optimal glycemic control. In the case of gastroparesis symptoms, which is a very devastating condition, there aren't really very much option. Dietary changes such as patients eating very frequent small meals throughout the day. Reglan, metoclopramide, is probably the main agent that's available, but then because of the tardive dyskinesia side effect, it's not certainly something the patient will want to use on a continual basis. For the erectile dysfunction, phosphodiesterase type 5 inhibitors such as the Viagra's are certain options for patients to use as well as some other prostheses and devices that the men can use as well. The goal with nephropathy management, really to reduce the risk or slow the progression of nephropathy, is really about optimizing glucose control and blood pressure. Again, you see, I'm saying the same thing with many of these complications, managing them by glucose control and blood pressure control. So with nephropathy, we can categorize the protein spill into the urine in probably in 3 categories, normal being less than 30 micrograms per milligrams creatinine, and microalbuminuria between 30 and 299, and macro 300 and greater. And this is especially important, nephropathy management, because it is the leading cause of end-stage renal disease. So in terms of the process of managing patients based on clinical trials for nephropathy, well, we have large prospective studies that have shown that, really getting the patient's glucose control is going to help to delay the onset of microalbuminuria and even the progression from micro to macro, both in type 1 and type 2 patients. And ACE inhibitors and ARBs are really great medications beyond blood pressure lowering benefits in helping to reduce the progression of the macro and the renal complications, really. And we realized with the UK-PDS trials we discussed earlier that blood pressure control is also important in reducing nephropathy as well. In addition, protein restrictions will be necessary to slow the progression for patients. So in summary, ACE inhibitors or ARBs, really both in type 1 and type 2 patients, could be used either or. And for those patients that have diabetes in the early stage of the chronic kidney disease state, protein intake restriction to about 0.8 to 1 gram per kilogram per day will be necessary. And those who are in the later stages, a protein intake restriction of 0.8 grams per kilogram per day will be necessary. Now, lastly, in discussing complications, I just wanted to bring this in. I know we've been talking about chronic complications, but acute complication that's very severe and very serious for many patients who have diabetes, whether it's type 1 or type 2, is in the case of type 1, diabetes ketoacidosis. In the case of type 2, hyperglycemic hyperosmolar state. Those are states whereby patients have really about little to no insulin present, and as a result, they experience severe hyperglycemia state. And in the case of type 1 patients, they tend to have blood glucose about 250 to 600 milligram per deciliter. And with type 2 patients, it's going to take a little bit more for them to experience this. They tend to have blood glucose levels between 600 to 1200 milligram per deciliter. In a nutshell, the point I want to make is that these patients tend to have insulin deficiency, volume depletion, and acid-base disorders. And they're generally managed the same way through rehydration, insulin administration, and electrolytes correction. In summary, diabetes complication is really common in uncontrolled diabetes. So getting the patient control is going to be so important to minimize those diabetes complications. And cardiovascular complication is still the leading driver in the clinical burden of diabetes. And the exact mechanism of the diabetes complication is still not fully elucidated. But we do know that getting glucose control and blood pressure control are going to be quite important in reducing the complications. And so that's why it's going to be important for us as healthcare providers, to help the patients by helping them to make sure that they get the routine screenings that they need, achieving the glycemic control and blood pressure control, blood cholesterol control, body weight control, smoking cessation, antiplatelets if applicable, to get them to reduce their diabetes complications, to certainly prevent, delay, or decrease their severity. Thank you.